Recording. There it is. This meeting is being recorded. The recording will be posted on the board's webpage shortly after the meeting. TBW might be joining and supporting the live streaming and might archive it after for additional viewing opportunities. We have as always, a busy agenda today, but just 2 hours. Thank you again for joining. At this time, I'm going to turn it over to Michelle Needham, Interim Chair of the Healthcare Cost Transparency Board, who will call the meeting to order.
Thank you, Kaylee. Welcome, board members. And at this point, I'll call the January 30th meeting of the Healthcare Cost Transparency Board to order. I see there's very few board members actually electronically joining the meeting yet. You can check the waiting room. As we turn to roll call, and pause to see if more of them are joining us. Okay. I will start roll call and we can come back as we see additional board members join the meeting. Jane Byer. Eileen Cook.
I'm here.
Lois Cook.
I'm here.
Bianca Frogner.
Here.
Ken Gardner is a brand new board member and he was expected not to be able to make it today. Jody Joyce. I am Jane Byer. I'll call you again. I see you just joined.
Yep, I'm here. Thank you.
Great. Greg Marchand. Mark Siegel. Margaret Stanley, expected to not be able to join us today. Ingrid Ulrich. Present. Kim Wallace. You online?
Yes, here, thank you.
Cheryl Wilton.
Here.
China's in the room. And let's see, any other board members joining since I don't think so.
Jody Joyce.
Jody Joyce is joined?
Yep.
Jody Winchester Sound?
Yeah, Jody's here. Thank you.
Great, thank you. All right, thank you. Let's tune to our next item on the agenda, which is approval of the November and December meeting summaries. Those are behind tab 2 for those following the book. I believe, yeah, the November meeting summary is also being shared online at the moment and is posted on the webpage. Is there any discussion of the November meeting summary? I apologize to staff. I did notice a couple of small corrections that I didn't catch before the materials went out. I didn't read them. Sorry, it's been an active flow. So page 2 of the November meeting minutes and the best practices report, could we add in that second paragraph from the bottom around the 8 states being captured, add Rhode Island to that list, please? That was just missed.
There's just 7.
Yeah, and then throughout this document and the December meeting, if we could just do a slight edit for the healthcare, just 2 words throughout this document. Kim Wallace.
Yes, under Jeb Shepherd's testimony in the first paragraph at the beginning of the minutes. Yes, right there in the first paragraph. I guess I just a minor point for clarification. There is a statement toward the end of the paragraph. The line that starts physician groups should reflect. That statement, that I think the word should be deleted, indicating that costs attributed to physician groups reflect contracted hospital, right? The statement is that I believe this Jeb's statement was that they reflect hospital rates beyond their control. Not that they should.
Okay, thank you.
Does that make sense?
Yeah.
Jim is in the room and he said yes.
Okay. Okay, thank you. And one other comment about the recommendations that appear, the board recommendations that were captured in the notes. Let's see what page. I'm sorry, I didn't write down the page. Scroll forward. Right there, recommendation 1 and recommendation 2. In the, let's see, in recommendation 2, in the third line, the sentence reads, reporting should include any acquisition or ownership state by a private equity firm. Minor thing, I think that should be stake with a K. Is that right?
I do think that's right, Kim.
Okay. Thank you.
Okay, thank you. Any other comments or corrections for November?
Bianca.
Bianca?
Hi there. I just caught one small typo. It in the part that says and calls out it's the prices stupid article. It says Gerald Anderson is Gerard, Gerard, not LD. And it may be helpful to say what journal that's in, which is Health Affairs. I could give you a year. I think it was 2001, but I'm not positive.
Okay. Any other comments? Is there a motion to approve the November meeting with those modifications?
So moved.
A second? Second. Thank you. All in favor, say aye.
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 Thank you. Any opposed? December hearing summary. That's on the screen now. Any discussion around December? Not seeing any hands or additional comments. Is there a motion to approve the December meeting?
So moved.
Is there a second? Second. Thank you. All in favor, say aye.
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 Any opposed? Okay, great. All right, let's turn to tab 3. We'll turn to public comment. There you go, public comment period. I don't believe there's any public comments that received in writing, nothing behind that tab. If there are people signed in, we will have Kaylee start to read those names. You will please raise your hand if you're wishing to comment, and Kaylee will call on you. At that point, you'll be promoted to a panelist, so that you can unmute your microphone and turn on your camera.
Great.
He does want to timer today, and Jeff is wishing to testify here in the room. Kaylee, to start with Jeff.
Great, sounds good.
Why don't you come up to the table? Sorry, we're unprepared for. That's why he'll live action.
Sure. All right. Thank you. Chair Anita, members of the board, good afternoon. For the record, my name is Jeff Shepard from the Washington State Medical Association, representing nearly 13,000 physicians and physician assistants across the state. I'd like to focus my brief remarks mainly on the draft advisory committee charters that will be considered on the agenda later today. We think it's a great idea to have this document. We kindly request inclusion of what the feedback loop looks like between the advisory committees and the board. We think that would be an appropriate element for a charter. Because at various points that feedback loop has been unclear to some members of the advisory committee. So I think the charter document is a great opportunity for us to get on the same page in that regard. And then finally, I want to thank you all for considering revisiting the attribution method for potential tweaks. If selected by the board to look at that again, I think it would demonstrate to stakeholders a willingness by the board to refine this program over time in partnership with the advisory committees. And that would be very welcome and appreciated. So we urge you to approve that activity. Thank you.
Thank you, Jeff. Haley, are there other assignments?
Yes, first up is going to be Katarina LaMarche, followed by Rosemary Adamson.
Hi, yeah, thank you. Katarina LaMarche. I'm a policy director at the Washington State Hospital Association. I just wanted to echo what Jeb said. We want to thank the board for including a review of the attribution methodology as a potential advisory committee assignment. It's really important, we think, because improving that process will help providers better understand their growth and be able to make actionable changes. And I know we've submitted a handful of letters with suggestions, and we would be happy to recirculate those for reference if you would like. Thank you.
You and Rosemary Anderson is next.
Good afternoon, and thank you for the opportunity. My name is Rosemary Adamson. I'm a practicing physician in Seattle. I specialize in pulmonary and critical care medicine. I'm also a member of Washington Community Action Network. And I just wanted to take this opportunity to encourage the board in its mission to increase transparency for patients and taxpayers, and to thank you for your work in this area. Navigating the Byzantine healthcare system in the US is a challenge, even for a trained doctor like me. My interactions as a patient in the US really started with my first pregnancy. I was on private insurance, an employer-based HMO plan. After I gave birth to my first child, after a medically uncomplicated pregnancy, I received bills for tests and procedures that were explicitly covered under my policy. As a sleep-deprived new mother with my imminent return to work after 8 weeks looming large, it was very stressful to negotiate for coverage that was mine to start with. It took several monotonous, repetitive phone calls during which I had to stand my ground to get these requests for payment for covered services rescinded. I am sure that this happens all the time to people with less English language proficiency, confidence, education, or experience with the healthcare system, and carriers rely on patients not knowing their rights and giving up. I moved to the US from the UK, where I had received healthcare when needed without bills. I strongly believe that healthcare should be a right rather than a privilege. While that is not the current situation, cost control and transparency are crucial in many ways and should help to reduce patients needing to fight for the payment of their care. Thank you for your work.
Well, I do not see any additional hands raised.
Great. Thank you all for your public comments, and thanks, Kelly, for running that. Let's turn to tab 4 at this time. And again, a reminder again, if you have additional comments you'd like to share with the board, we do accept those in writing at any time on the email address. So we have a few operational updates we wanted to share with the board and the public, and I'll try to remember to yell at the ceiling. Sorry, I did get a note that says the room is hard to hear for those listening online. So let's all yell at the ceiling. Yelling at the ceiling. Yes. So our staff updates I wanted to share today. As many of you are aware, we do have a new interim Healthcare Authority Director. Mary Ann Lindblad has been named by Governor Ferguson, and she will be serving until we find a new permanent director. She has chosen not to start sharing all of the committees on an interim basis, so we will continue with our interim assignments. Very significantly, I'd like to introduce Ross Valori, who is in the room with us today. He is the new director for the Board and Commissions unit. Ross, would you like to introduce yourself?
They're not hearing you, so.
They're not hearing us at all?
Well,
Oh, just me, okay.
Sure, I'm happy to try and speak up. Good afternoon, all. Very nice to meet you. My name is Ross Valori. I am the new Board and Commissions Director. I am coming from the Department of Health, where I led the Certificate of Need program for the past few years. And then prior to that, had worked in legal roles for Office of the Insurance Commissioner, and was very fortunate to get to work with Jane, who I know is a member of this board, and I went to the Department of Health and did legal positions there as well. Really excited to be able to dig into the cost transparency elements. Certificate of need is a very regulatory process for those that are familiar with it, and something that we had always wanted was this capacity to think about long-term planning for Washington and for our future generations. And I think the transparency and cost element that this board works on is incredibly exciting. And just a little bit more about me. I'm from the Detroit area, gigantic Detroit sports fan, Michigan sports fan. As strongly as I feel about Michigan sports is how much I dislike Ohio State. So I'll just say that. And just for a moment, just to speak to kind of the why for me, 2021, we lost our daughter, and that was an incredibly challenging process, as you can imagine. She had a very rare genetic condition, and so we found out pretty late in the pregnancy, and we're able to, work with really well-qualified professionals to kind of help us through that process, but the condition was not able to be survived. And, working in legal regulatory positions, I've been on kind of the outside looking in to a lot of different, how the healthcare system works, but then kind of being on the inside and really having to work through those crises and being able to see all the staff that support it, but also the regulatory structure that we help create as, government employees, and how important and crucial it is to ensuring we all have access to that high quality care was a really defining moment for me. So I'm really excited and grateful that I get to be here and work with the cost board and the commission team as well. So really excited to be here, and thank you.
Thank you, Rob. We have a couple of new staff I just wanted to introduce very quickly that have joined the team in December. Jen Scott and Harrison Fontaine, both senior health policy analysts that will be supporting the two committees that also service this board. And Josefina is in the room with us. She has been a lead drafter of some of our performance benchmark reports, and she is unfortunately leaving us in February. So we want to thank her for all of her work to support this board. And last but not least, it is not in my notes, but no, we don't go to Ken yet, please. I just wanted to say Ross will be transitioning and working very closely with Kaylee. I want to call out Kaylee's support for this board work since she took that over in addition to her other full-time job starting in October. She has really been doing yeoman's work, helping us move this along and supporting the team and all of the activities that you have seen over the last couple of months. So I want to call out Kaylee Dufresne for her amazing work helping us keep this going. Thank you, Kaylee. Then we can turn to the new board appointments. As you may have seen by the roll call, we have a brand new board member, Ken Gardner, who was appointed by the governor before he left office. Ken will be joining us for our March 5th meeting. He is currently serving with SEIU 775 Benefits Group. He's the Director of Growth and Administration for their Health Benefits Trust. He has also served with CMS in a variety of positions. I'm not going to read them all. And since she's not here, we can go over some of this again when he joins us in March, but we're very pleased to have him join the board.
Michelle, I know Ken is not here, and he communicated with me earlier. I just want to say I'm excited that he'll be joining us. He was serving at CMS at Region 10 when I was at HHS, and he will be a great addition.
We're very excited.
Yeah.
Excellent. And then we can turn to the next slide, which is a picture of the board meetings and committee meetings that have been scheduled for all of 2025. So I hope you have those on your calendar, and obviously we will modify it as needed as we go through the year, but that's what we have filed with the co-advisor for our public meeting schedule. Any questions or comments around the board schedule here? Well, then let's turn to tab 5. And I will turn the meeting over to Carol Wilms, who will be giving us an update on the nominating committee meeting.
Great, thank you. So the nominating committee met last week, and we have a couple items before you today for board approval. Oh, hey, Chris.
I missed the news.
It's fine. It's great. It's just how it goes. We have a vote that needs to occur for the nomination of the stakeholder advisory committee. This is to fill the slot for ambulatory surgery center representative. The Ambulatory Surgery Center Association submitted 3 very qualified applicants. It was a discussion and certainly a tough choice to pick one out of the 3, but the one that we are bringing as a recommendation to you, Jamie Fowler, her experience and her background seem to align best with the work of the Stakeholder Advisory Committee, and then as a recommendation body to the board. We'll go on to the next before the board maybe takes action. There was also a recommendation to make for the Data Issues Advisory Committee. This had 1 member to recommend to you, extremely qualified, background, education, and experience. I'm going to not do justice to the name, I'm sure. Dr. Nabuchi Anekpezi. Apologize if that is incorrect. Is the Senior Director of Health Systems and Workforce Intelligence with the Executive Office of Healthcare Innovation and Strategy at Washington State Department of Health. So again, a very qualified recommendation before you today for that committee work. So with that, I'll turn it over.
Okay, thank you so much for participating in the nominating committee and bringing forward recommendations. Is there any discussion or questions about the nominations?
Good work.
All right, is there a motion to adopt Jamie Fowler for the Stakeholder Advisory Committee?
I move.
Is there a second?
Second.
All in favor, say aye.
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 Any opposed? So carried. Is there a motion to approve the member for the advisory committee on data?
Oh, come on. I move that we approve Dr. Anekpezi.
Excellent, thank you. Second?
Second.
All in favor, say aye.
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 Any opposed? Okay. Wonderful. I think we're back to you for more discussion.
Yes, yes. So one more item before you is a change proposed to the committee charters, and it relates to the attendance policy. And you know, certainly important conversations occur at the committee level for recommendations to the board, and the continuity of conversation and attendance in those meetings is important. And so an addition to the charter, which is in its full form in the packet, there's a red line edit that will show that regular attendance of committee members is essential for the work of those committees. If a committee member misses 3 meetings in a calendar year or 3 consecutive meetings over a 12-month period, they will be notified by a staff member of the healthcare authority and of being removed due to attendance.
And I assume that this also means Zoom attendance, not just in-person attendance.
Ah, yes, I think that that's passive and
I think that's what, yeah, I
Yeah.
think that's what you mean, but I just
yeah,
know if we
I
need to.
believe the committee structure as far as meetings go is
Does it
that
say?
they can be virtual, but that's a good thing to check.
Yeah, I can say the intent is definitely all attendance, be it virtual or otherwise. We can clarify that in the language if needed.
Any other discussion about the proposed policy change charter? Bianca?
I just, thank you. I certainly agree that there's a need to make sure people are attending regularly. So I'm generally supportive of this. I just want to make sure that we're not removing somebody who might have some extenuating circumstances, like say there is a death in the family or, some significant disruption in someone's life that we're kicking them off when they might otherwise be a committed member. So is there any exception to this rule? Just want to make sure that we're not being insensitive to, probably justifiable reasons why people are not able to attend.
Sure. We did not talk about it at the committee level. We did have a brief discussion about excused absences versus non-excused. Did not include that language in the committee here, but if that's the board's desire to do so.
I don't know if it's something as simple as adding something like, I don't know, some clause that says something like upon review or something like that, or with select exceptions or something to that degree. I'm not great at the wordsmithing part of it, but it doesn't have to be like a long list, but perhaps just something that gives us an opportunity to consider that there could be somebody with a reasonable reason why they're not there. Maybe it's something like, upon assuming, or I don't know, something like reasonable absence or something. I just don't know what reasonable would, how well that holds up in court, like what that word would mean.
Lois is suggesting a medical excuse or something like that.
I guess Bianca, I'm going to push back a little bit because there's only 4 stakeholders and data issues meeting in a year. And if they miss 3 of them, I think, and even if it's a medical reason, maybe they should resign for medical reasons. I think we have to be cognizant of the fact that the group's there to be advising, and if they aren't, if the member can't participate, I mean,
Remind me how many years our committee members or advisory members are usually on a board, on these committees?
Is it a 2-year one?
They don't actually have designated time attached to them for the committee.
No.
Board members have specific assignments from the governor.
Right.
That might be a separate issue to consider.
Yeah, that is it.
Because if they're on there indefinitely and then they miss 1 year, then in the life of a committee member, it could be quite short. But if I certainly get your point, Eileen, that like, certainly if they're like they're missing a whole year. I mean, certainly I get that point. And it's particularly notable if they're time limited in terms of their committee appointment. I didn't mean to necessarily, stall this. It's just recognizing that sometimes it could be. Just want to make sure we think about all situations that might come in front of us.
So Carol, do you think you need to take it back, or what? That's the question.
I actually am in agreement with you on this, Eileen. I mean, I want the board to speak out, but the committee work and the discussion is just so fluid from meeting to meeting. Missing a meeting is understandable, even too if it's an illness or in the family or of self is extenuating. But I think if it's serious enough, then they maybe need to excuse themselves from the committee's work for now and then come back at a later date. There's nothing that says that they are, banned for life in this realm, but maybe, it's better that someone else can sit on a committee who can commit to the work if there's something more serious going on. So I really do feel that this is appropriate for both of these particular committees, that the continuity of conversation and the commitment to that work is important. So I like the way that this is written, the way that it is. It's simple, but again, support the majority of the board if that's what's needed.
I concur. Okay. Any other discussion around that?
Well, I would just like to confirm that I do see 3 meetings and then I see in parentheses 50%. In my mind, that suggests that there are 6 meetings in a year. And Bianca just mentioned 4. And so then my brain kind of tripped up over that a little bit. And then I thought to myself, do we need that parenthetical figure there, 50%? Does it really add anything important? It seemed like it was kind of informative. It was like saying 3, well, that's 50%. But I
Yes.
would trip over, well, what if there were 5 meetings in the year? Or what if there were 7 meetings in the year? And that's not 50%, 3 meetings isn't 50%. So I'm kind of wondering if we could amend it by removing the mention of 50%, if we really mean 3.
That makes sense, Ken. Yeah.
Good catch.
Yep, good catch.
And actually, I mean, to this note, I mean, the number of meetings certainly vary, I think, by year to year, as my understanding is that these committees come together in response to what the board wants. So if the board is not asking them to convene very often, it could even be less than 3 that's even happening in a year. So just noting that. I think we're aiming for at least 3 in a year. But there's nothing that's driving that we have to have even 3 in a year, I believe.
That's correct.
Speak up.
That is correct. Nothing,
Yeah,
nothing dictates the minimum number of meetings. It is up to the board and the assignments that we send down to those committees. So I hear a suggested edit to remove the 50%, and I have not heard other edits at this point from the committee, from the board members, sorry. So at this point, would we like to take a motion for adopting this policy?
I would move to adopt as amended by crossing out the 50%.
I'll second that.
All right. All in favor, say aye.
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 Any opposed? Okay. Thank you all. Thank you, Carol, for managing this process. All right, let's turn to tab 6, and we will begin the main topic for today's board meeting discussion, a review of the performance against the benchmark analysis that we had an extended conversation around in December. At this point, I will turn it over to Amanda, who's going to lead this discussion. Amanda, you're on mic.
All right. Thank you, Michelle. Thank you, everyone, for having us again back. My name is Amanda Avalos. I'm Deputy for Enterprise Analytics Research and Reporting with the Healthcare Authority, and I'm presenting on behalf of the Cost Board Analytic team. We're going to do some reviewing of the findings that we talked about in detail in December, and we also have a follow-up related to some of the questions that came from that conversation. Next slide, please. So as I mentioned, we'll do some key takeaways just to kind of reset and remind ourselves what we spoke about last month. We'll specifically go through the individual questions that came up in that conversation. And then we'll move into next steps where we're talking about the benchmark performance, and then we're relating to the next analytic project, which is the cost driver analysis and comparison between the two. And then we'll also have time for discussion. Next slide. All right, so this slide is to remind us a little bit about the fact that there are numerous analytic initiatives associated with the cost board. And specifically what we'll talk about now is the performance against the benchmark, really assessing cost growth, and that'll be the focus of this conversation. Next slide. All right, so this gives us a nice overview of all the different parts of this analysis. So we are looking at Washington State total healthcare expenditures, and we're breaking that down in a number of different ways. We'll get into some detail around what's happening at the market and the carrier and large provider organization. We'll also be looking at other spending, potentially Veterans Affairs, Department of Corrections, L&I. The data sources that come from the analysis we're going to talk about today. To remind you, this is data that's collected specifically for the cost board from carriers who operate in Washington. We also get data from the Healthcare Authority and CMS, as well as Office of Insurance Commission data is also included in part of this. Next slide, please. As you probably remember, 2022 is the first year that the application of the healthcare cost benchmark has occurred. Here on the left, you can see that the benchmark has been set by this board for multiple years out. We're at the first year, 2022, and we're looking at that benchmark at 3.2% and hoping to have healthcare growth under that benchmark. Next slide. All right, so we're going to be looking really at a high level aggregate information for this, really the cost growth performance as it relates to the benchmark. We're going to be aggregating and looking at the statewide level, various markets, carriers, and large provider organizations. There's a lot of information that's behind all this data, so I'm going to direct you to, if you're interested in unpacking some of the methodology behind it, there's a benchmark brief, and then there are the appendix that's attached to the slide deck, so you can look in more detail around attribution, truncation, the age, sex, risk adjustment, and more detail is available there. Next slide, please. All right, so this is a reminder of the key takeaways for 2022. So as we mentioned a moment ago, we have this 3.2 growth benchmark. What we saw is that for 2022 statewide, the per member cost growth was 3.6. So that was slightly above, but it was also the slowest growth that we'd seen in the state since 2018. And now when we look at the markets, we saw that the Medicare market was the only one that exceeded the benchmark. We looked at carriers and saw 5 out of 12 carriers, and then large provider organizations, 5 out of 28 exceeded the benchmark. We also saw that VA members also pushed growth. But one key point here is that looking at the year-over-year analysis didn't really tell us the full story, particularly with everything that was going on during the pandemic period. Next slide, please. All right, so we had to look at more data. So we went back and looked back to 2019. And here, when we were looking at a larger time period, we saw that the per member spending growth was driven by the commercial and Medicare markets. We also saw that VA spending was also part of that. We looked at the top contributors of per capita spending growth from 2019 and 2022, and what we saw were prescription drugs, non-claims, and hospital outpatient. We also looked at Medicaid spending, and we saw per capita decreased from 2019 to 2022. There was a decline in other claims, but there was also an uptick in prescription drug spending for Medicaid. Next slide. All right, so I'm actually going to hand it to Kaylee right now. She's going to talk a little bit about the public hearing stakeholder reflections. Kaylee.
Thanks, Amanda. So that was a great summary, just a reminder of the high-level takeaways from that performance against the benchmark analysis. We also wanted to remind you that we spent a good amount of time at the public hearing in listening mode. We had 3 different reflection panels that we invited to speak to you. The first was about consumer affordability in the state. We had a few consumer representatives join us. We had a business and labor panel representing the challenges that employers and labor in Washington experience. And then we had a carrier and provider panel. So listed on this slide is just a few of the key points that we heard. I won't read them in detail, but just to say at a high level, the consumer panel really reminded us they had done a great survey of consumers in the state that revealed the challenges of healthcare affordability in the state and how that translates to folks avoiding care or being unable to access care. Employers brought up some really interesting challenges that they experience with just understanding, having transparency and visibility into the costs of the system and where the money is going. They raised that particularly around prescription drug spending, as well as some other categories, including out-of-pocket spending and consumer burden for their employees. And then in the provider and carriers panel, they talked a bit about how inflation has really driven costs in the last 2-3 years, which was more a reflection of more recent data than what our performance against the benchmark analysis reflected. And they highlighted that there's truly different experiences in delivering care in rural versus urban areas. We also wanted to call attention to some concerns raised by providers and carriers regarding the data collection and aggregation approach. And in particular, really related to that attribution process, that there was concerns that both how that methodology is carried out, but also if it is truly giving you adequate insight into provider costs and how those costs are distributed around the system. There was also some questions about the ability for HCA and the board to be able to provide TIN level reporting, tax identification number reporting to individual providers so that they could drill down into a facility level rather than an aggregate system level to be able to best address any kind of cost growth that we're seeing. So some real great feedback that we heard, some good opportunities. I just want to put this nugget in your mind now, and we're going to come back to it at the end of this agenda topic today as some potential committee assignments that we want you to consider. Next slide. Okay, so these are the questions that we heard at the public hearing. There were a number of other questions that we were largely able to answer live, but these were the ones that really incited a lot of good back and forth among the board members and required a little bit more research and deep dive from the staff. So first, really thinking about comparing Washington to other states and seeing if there was any impact of different primary care related interventions or primary care spending and how that might impact broader spending. Next, you asked us if we could break out carrier performance against the benchmark by market. So we're going to bring you some of those results today. Next up is how Washington's expenditure growth compares to other states. We had kind of a deeper breakdown of that, in particular by payer type. Next up, we had some really good back and forth at the December hearing about non-claims expenditures. This is one of the spending categories that we assessed by payer type and had some surprising results in that non-claims category. So we wanted to do a little bit of a deeper dive on that with you. And finally, there was some great expertise shared with us about some different trends in inpatient and outpatient hospital spending that we wanted to go a little bit deeper on. And this one's great because it'll help tee up for us the difference between this performance against the benchmark, which is what we're reviewing today, versus that deeper cost driver analysis that we're going to get to. And I just want to say, please do feel free to jump in and interrupt with questions or comments. We have some good time for discussion today, and we would love to hear more from you on this performance against the benchmark analysis. Next slide. All right, so the first question raised from us came from this image showing the total healthcare expenditures per member per year growth. And you all were interested to hear more about, Washington's performance is kind of middle of the pack fairly consistently over the last few years. And you were sort of curious to learn more about, particularly those states where growth has been a bit lower than in Washington. Are there some primary care initiatives that those states have been running that might support the idea that they're preventing more acute spending? And could we give you some insights about their primary care expenditure ratios? Next slide. So we dug into that a bit, and this is just a 20,000 plus foot level look at some primary care initiatives in these other states. Most of them have programs very similar to what has been going on in Washington. There's initiatives to measure their primary care expenditure ratio, that is the primary care spending as a proportion of total healthcare spending. They also have initiatives with perhaps with CMS or internally with a multi-payer initiative about transforming the way that primary care is delivered in the state, bringing in more primary care medical home type of initiatives or progress for primary care practices and building their capacity. I would just call out a couple of Oregon and Connecticut. Those two states both Oregon and Rhode Island both participated in the comprehensive primary care plus model with CMS, which was kind of a precursor of sorts to the Making Care Primary model, which we and Massachusetts are in now. And in some ways is, the primary care portion of AHEAD, which is what Connecticut is in now too. So very similar initiatives in many of these states to try to drive primary care spend and focus on getting more practices into these alternative payment model approaches. Next slide.
Kaylee,
Please, go ahead.
Can I just jump? Can we go back? Oh,
Yeah.
Good. You're gonna let us know in this next slide where they actually are with respect to spending. Perfect. Thank you. You read my mind.
I love when I'm able to do that, Jane. Okay. So we did take a look into their primary care expenditure ratios. I want you to take this table with a pretty huge grain of salt, noting that there's no shared definition of primary care. Each state has their own definition, and we weren't able to do a, code by code review to compare those definitions. In particular, you'll notice that Oregon's reported primary care expenditure ratio is quite a bit higher, but they include a much broader scope of behavioral health services in their definition, so that's probably informing that higher spend. So we did pull from our data call data that we used for the performance against the benchmark. We did pull in that what our overall primary care expenditure ratio was by the reported data from the carriers. I will note this, what's shown here, I think, is a little bit lower than some of the numbers that we saw from OnPoint over the last couple of years who used our APCD. It's also a little bit lower than what we see in self-reported primary care expenditure ratios from our PEB-SEB carriers at HCA, from Medicaid MCOs, and from public option carriers as well. Those typically tend to be more in the 5 to 7% range once you add in kind of non-claims and some other categories there. So roughly similar, if not maybe a little bit lower than some of these other states. Pause here and give you a chance to digest and see if there's any questions.
So Kaylee, Jane, quick question. I'm looking at the Connecticut where their Medicaid percentage is so much higher. Is part of that premised on their Medicaid program being a primary care case management model where rather than Medicaid managed care contracting? Do you think that's part of it?
It could be. Could be. We could look into that.
Yeah, it's just so different than the other markets.
Yeah, Massachusetts is also a little bit higher there too, and they have their ACO program that they've had in Medicaid for a few years now. So,
okay, thanks.
Great question. Okay, I think we can go on to the next slide. I'm going to hand this back over to Amanda.
Thank you, Kaylee. All right. So now we're looking at carrier performance against the benchmark. This is going to lead us into question number 2. But just to orient you to this visualization, you see that red dotted line right through the middle. That is where the benchmark is. If it's to the left of that line, then they are performing below the benchmark, which is what we're looking for here. And so the question number 2 that was asked was wanting to have a breakout of carrier performance against the benchmark by market. And so the next few slides will do just that. So next slide, please. Right, so here we're looking at the Medicaid market. And what we're seeing, again, this is 2022, what we're seeing as the growth rate, total medical expense per member per year, is that none of the 5 carriers exceeded the benchmark when we look specifically at the Medicaid market. And next slide. And so now we're moving to the commercial market where we're seeing a little bit of more mixed results here. So again, same visualization and looking at that dotted red line, it looks like 4 out of the 10 carriers exceeded the benchmark in commercial market specifically. And next slide. Now we're moving into Medicare Advantage market. One note here is that Medicaid fee-for-service is excluded. Unfortunately, they do not report data at the large provider entity level. So we're focused here on Medicare Advantage specifically. But for context, in 2022, that was about 46% of all Medicare beneficiaries, so almost half. But what we do see here is quite different. 9 out of 11 carriers are exceeding the benchmark when we're specifically looking at Medicare Advantage. All right, so next slide is average growth across states. And what we're starting to look at here is question number 3, which is how does Washington expenditure growth compare to other states? And so what we have in this visualization is really that comparison between Washington and other states by market. You can see statewide, commercial, Medicaid, and Medicare. Washington is in orange, and so you can see us generally showing up around the middle of the pack during these time periods. But you can see some more on this next slide. So, it looks like we have a question. Kim.
And maybe you're going to get to this. In the previous set of slides regarding the carriers, we were seeing their growth rate performance. I guess I was wondering, do we have can we see, or do we have a comparison of the carriers in terms of their total medical expense, or this where they stand in terms of total medical expense that could be a kind of part of the story, the other part of the story when considering their growth rate? Does that make sense?
Can we go back to the slide? Which slide was it? Can we go back a couple slides to? Was it when we broke it down by market?
Right. I was just thinking that, with the growth rate of total medical expense by market, in considering these data, I was thinking, I wonder where the carriers actually stand with regard to their total medical expense. There's one growth rate is one thing, but the growth from X to Y is another aspect. And so anyway, I don't know if that is presented and later or is under consideration, but I just felt compelled to ask about that.
That's a great question, Kim, and you're right. That's very distinct and different. And I see
very different.
Popped in and with his hand up, and maybe you'd like to share some comments, Vishal.
Yes, Kim, we can definitely take that look. We have that information. So in other words, if I may reframe what you're trying to say, please correct me if I'm going in the wrong direction. You're trying to understand, well, what is the actual contribution of each of these carriers to the overall growth? Like which of these bubbles, if we were to do a volume-based bubble on each of these, to say which is the largest bubble, smaller bubble, that kind of stuff, right? We have that information by way of the total spend, yes, and also by the number of lives that are covered by each of the carriers. So we can do that. Not quite sure what actionable information would come out of it, but that's not for us to decide. It's a follow-up question. We'll take that back and we'll try to put that in.
Okay, yes, thank you. Thank you very much.
Thank you, Michelle. Ingrid has a question as well in the room.
Thank you. Just asking, this is really interesting to see the data by market. And just a reminder why we don't have individual market data. I know it's a very small slice of pie, but just wanted to ask. And then our awareness is that we've seen 10% increases, premium increases per year on average for the last 3 years. So very high and compared to some of the data we're seeing on the other market areas. Any comments?
Michelle, would you like to?
Ingrid, if I heard your question correctly, you're commenting about the individual market specifically.
Correct.
Is that right? Okay. So the individual market.
I was down at the ceiling. Yes.
The individual market is captured as part of the commercial market. We can break that out, I believe. We haven't done that in this analysis, but we can do a follow-up analysis if there is a need for it. This is really at the market level, which is capturing all of commercial together, including PEB and SEP, for example.
Michelle, correct me if I'm wrong. I believe the cost driver analysis we're bringing to the March meeting may have that breakout a little differently than the aggregate data call that we did on the benchmark.
Yes.
So the individual market is identified a little differently in that next set of data.
Okay. Good, thank you.
That is correct.
Amanda?
All right, so we can move forward a couple of slides unless there's further questions. Okay, so yep, there we are. So now what we're looking at is the comparison of state growth trends. And so we're thinking of here in the gray, if you look at the gray versus the orange, Washington is reflected in orange. The gray is the median for the 5 cost board states. And so you're able to see here by different market, Washington growth trends alongside theirs. And so what we really see is that it's pretty comparable across these states that have similar cost containment efforts. Even those that, like for Medicaid, for example, we didn't see quite as much growth here in Washington, but there were other states that had less growth and reductions in their growth trend as well. And next slide. All right, so what we're looking at here, and we saw this slide previously, this is teeing us up for the questions number 4 and 5. We're looking at service category cost breakdown at a state level. And to orient you to the information here, right in the middle, we're looking at the statewide per member growth for each category between 2017 and 2022. And then here on the right, that's the contribution to year-over-year growth. And you can see the different colors. The light blue down there shows the decline in hospital inpatient. Really the key point with this slide is that we were finding the top cost drivers for growth to include prescription drugs, non-claims, and hospital outpatient. And this is at a state level. Next slide. And so now we're moving to look by market at these contributors to the total medical expense over time. So here on the y-axis, you can see the percent change to the per member per year. And the x-axis is showing us the per member per year spending for 2022. And then that size of the bubble corresponds to the contribution of overall growth during that time period. And so what we're seeing in commercial growth is prescription drugs, hospital outpatient, and professional specialty. And next slide. And so this is Medicare. It's the same time period. You got the same visualization. But really the highlights here is, again, those top contributors to Medicare growth. We're seeing, again, prescription drugs and hospital outpatient, which was similar to what we just saw in the commercial market. But we also see non-claims here. And just to let you know, we're going to dive more into that non-claims category in just a moment. But first, next slide. This is our Medicaid growth contributors here. So again, same time period, the same visualization. So what we're seeing in Medicaid market is very similar findings. So we're seeing the prescription drugs and non-claims as the top contributors to Medicaid growth. All right, and so that leads us into the next question, which is, what are these non-claim expenditures? What non-claim expenditures are driving growth in each market? And so the team went back and started looking deeper into non-claims. Next slide, please. So let's start with some definitions. So what is the non-claims category? It is payments that health plans make to provider organizations outside of claims. And I'll highlight that it's provider organizations, specifically. We talked a little bit about incentive payments to patients in the conversation in December. And this is very specifically payments made to provider organizations. And we have some examples, including incentives, risk settlements or recoveries, capitation, direct payments, and then our bucket of sort of the other non-claims payments, which could be things like care coordination fees and population health payments. Next slide. All right, so now we're starting to look at commercial market non-claims. And so we're breaking open that non-claims bucket to see what the contributors are there. So if you're looking at what kind of catches the eye first, orange is the non-claims other bucket, and that is one that shows up pretty consistently in commercial non-claims growth for the per member per year between this is 2017 and 2022. Also, we can see overall what we're finding is that non-claims in commercial is the fourth highest category of per member per year growth. And you can also see down the side other things that contribute. We also see recoveries, particularly in 2018, 2019, potentially related, as we're moving forward. And we see that again, also coming in 2020 and 2021. Next slide. So now we're moving on to Medicare non-claim spending. And again, we're looking at detail you can see between 2017 and 2022. So for this one, this is all Medicare. So fee-for-service and Medicare Advantage are both included. And what we're seeing is that capitation and bundled payments, that's the subcategory you can see here in green, pretty consistently higher than some of the other categories of non-claim spending. One thing I would remark, even though fee-for-service is included in this data set, only Medicare Advantage had non-claim spending. Another point of note is that Medicare Advantage enrollment grew by 62% during this time period that we're looking at this visualization, while Medicare fee-for-service enrollment declined by 5%. And one other thing to also note, since this came up in conversation, that the category for non-claim spending excludes non-health supplemental benefits like fitness membership. So that's not collected. That's actually not part of the data call. That would be separate and not included in the information that is submitted from carriers. All right, next slide, please. All right, and so now we're looking at the same visualization, except this time we're looking at Medicaid non-claim spending. And we can see that 2018, 2019, there was quite a bit of growth in capitation and bundled payments. But what we're seeing, though, that declined and non-claim spending in general, and including categories such as capitation and bundle payments, did also move much slower post-pandemic. All right, and next slide. All right, question number 5. the last question I think that we're going to have for this conversation. And we're asking, why do the markets have different inpatient and outpatient hospital spending trends? And I think I see a hand. Jane.
Yep, can we go back a sec? And
Certainly.
I'm sorry if you already said this. So I'm looking at the categories of Medicaid non-claim spending. And especially on the commercial, when you noted how big a chunk non-claims other was. Do we have, I mean, because you've got capitation, you've got performance incentives, you've got population health, you've got provider salaries, recoveries. Do we have any idea what the other is, the non-claims other is?
We, when we have it in, I think that comes from directly from the technical manual potentially. So population health payments could be in that other, as well as some care coordination fees, but it also is sort of that catch-all other. So things that aren't specifically articulated, but are payments that go specifically to provider organizations that are not otherwise represented in any other aspect of the data collection. So there is a level of unknown potentially for that other bucket, at least currently the way the data is collected.
Yeah, I mean, given how much of an outlier it is for a commercial, it would be really interesting in getting a better understanding of where those dollars are going.
Yeah, that's a great point. Can we move to the commercial non-claim spending slide so we can have everyone look at that? I think it might be back one more.
Yeah, I mean, it's such an outlier.
Mm-hmm.
Yeah.
Absolutely. And that is one where we have less transparency on what this other non-claims other is comprised of.
And Jane, just want to note that, we may need to work with carriers to better understand what that means. It may be that their internal systems are not configured to account for the way the cost board is defining these categories. So we may need to work with the carriers a little bit to better account for and put more definition onto this, what I'm considering as a catch-all category, the other.
Okay, thanks a lot.
Thanks for the question. Any other questions before we move forward?
All right, I feel like I should know this, but so you said that for Medicare, the only non-claims is coming from Medicare Advantage. And you're saying that fee for service does not have non-claims because we don't have that data, or are you saying it doesn't exist? I thought that non-claims was a thing in fee for service, but maybe
So can we go to the Medicare slide? So we had two different Medicare slides. There was one that was missing fee for service. That was earlier, and that was because that for large provider organization data wasn't available from CMS. In this case, this is inclusive of all, but only Medicare Advantage had non-claim spending. So I can take that back to the team to make sure that it's not just because of the way CMS puts it out. They don't separate those buckets. That potentially could be the case. Or it could be that there is no non-claim spending. So that's something we can follow up on and get clarity.
Okay. Yeah, but I think I heard you say on this slide that fee for service doesn't have non-claims, but I think it's just being clear, why doesn't it not have non-claims? Okay, thank you.
All right, so we'll move back to the slide with question number 5. Okay, and we're moving into the differences in inpatient and outpatient. So we can go to the next slide. All right, so just to clarify around data sourcing, so everything that we've seen mostly so far has been specific to data collection, specific to the cost board. This is sourced from the all payer claims database. Because for this question, we needed to go in a little bit deeper than the aggregation that we have with the current data call for the cost board. So what we're seeing is inpatient versus outpatient hospital spending growth by market. To the left is statewide. Then we can see commercial, Medicaid, and Medicare Advantage. The blue is inpatient. The orange is outpatient. One of the things that probably is most striking as we look at this is that shift of spending from inpatient to outpatient during the pandemic time period. We see that in a couple different places in different markets. We also see, so Medicaid, if you look at Medicaid, which is the third one, inpatient per member per month remained more expensive than outpatient per member per month. And there didn't seem to be the same shifting from inpatient to outpatient that we're seeing in some of the other markets, particularly in the commercial with increases in outpatient. And then we also see in Medicare Advantage as well. And so the question that the board had is what's driving that? The perfect slide segue. So go ahead to that next slide, which is what is driving that? Is it utilization or price intensity? So this is the team diving into that question to look at the change in the outpatient per member per month during the pandemic time period. So we have two different time periods here. If you look on the left, that is 2021 to 2023. And then on the right side, we have 2019 to 2023. And then you can see it by each market: commercial, Medicare Advantage, and Medicaid. The blue, when you see the blue, that is identified changes that are likely due to price intensity. And then the green is changes due to utilization. And so some of the things that probably, strike pretty intensely, particularly as we're looking the 2021, 2023. You can see in the commercial market, those changes due to price intensity in blue. And then we also see on Medicare Advantage, at least during that 21-23 time period, it looks like the changes were due more towards the change in utilization. Which also comes up when we look at 2019, 2023 for Medicare Advantage. It does look like that change is really due to utilization during that time period when we're looking at the longer time period, 2019 to 2023. When we look at the Medicaid, we really see much smaller change to the outpatient per member per month, both on the price intensity and the utilization, especially when you're comparing back to the commercial and the Medicare Advantage market. Any questions on this slide? There's, I think, although I know we've got a lot other things on the agenda, so this is definitely one that if folks do have questions, feel free to follow up after, and we're welcome to take those as well in case there aren't any now.
So I have a question. So I'm looking at price intensity, and I'm actually a little bit surprised about the decrease in change due to utilization, given what we've been hearing about acquisition of physician practices that are then billed as hospital outpatient department visits. I actually thought that that would show up in utilization. So in change due to price and intensity, were we looking at sort of the same CPT codes, right, over the course of time?
Yep. And so there's a little bit of information you can see at the bottom. Really what they did is look at the change in the per member per month. If the average allowed amount per service had stayed the same and only utilization changed, and then the remainder of that change in the per member per month likely was due to the price and intensity of services. And this was looking at sort of that claim level, being able to look using the all-payer claims database.
Thank you.
So we can go ahead to the next slide unless there's any other comments. All right, and so at this point, I'll go ahead and hand it over to Vishal, who's going to talk to us a little bit about what's coming up next.
Thank you, Amanda. We can go to the next slide, please. So, in terms of where we're headed with this, just want to highlight the board has multiple data and analytics streams that inform the board's work. Two of them are the performance against the benchmark analysis, which how I like to think about it is it is probably closer to the source of truth than any of the other analyses because it comes straight from the carriers about how much spending actually happened in the state for healthcare for different purposes, right? It is at an aggregated level. It's good for some things, but then we need to get into other data sets and other analyses to get more information, like drill down or understanding, well, how about this and how about that? And what do we make of X or Y? So if we go to the next slide, there's a quick high-level comparison between the two in terms of, what are the different components and what type of questions that we can ask that can be answered from the different data sources, these two primary data sources that we have. One is the aggregate data reported by the carriers to the board as part of the data call. That happens once a year. And the other is the state's all-payer claims database. And I'm not going to go through each one of these. You can ask me questions if you have specific questions about these, but there is value. These data sets are complementary. The analyses are complementary. We can answer some questions using one, and we can answer other questions using the other. The intent is to provide the board with a multi-dimensional analysis of the situation, if you will, so that it gives you enough information to take those multiple perspectives into account as you make health policy recommendations. Not to say one is better than the other. I often hear people say, oh, this is great. Why do we need the other one? Well, because, it may seem like in this moment that's great, and it is. I'm not saying it's not, but there are other questions that are just as valuable to evaluate and answer. So I'll pause to see if there's any questions about this slide. We're throwing a lot at you, and I totally appreciate it. You don't have questions right now, but later, that's okay as well.
I think there are questions in the room. Carol?
Yeah. Could you explain what the asterisk means on next?
Yeah. We put that asterisk on the disease burden and the demographic analyses for data source from the APCD. It is the current cost driver analysis that is presented to the board does not include disease burden or geographic or demographic perspectives in it, but that doesn't mean it cannot, because the data are there. The data elements are available, but we could enhance the existing analysis that you will see next month at the next meeting. We could add those components to it if the board finds those valuable and meaningful. That's really what that means, Carol.
So data elements are available or are not available?
The data elements are available.
Okay.
Yes.
Eileen has a question.
And that kind of goes along with what I was going to ask about. So with the disease burden, I know that like from DOH, we have immunization rates, you have smoking, rates in the different areas. So are we at any point going to look at that to compare the increase in healthcare costs? I mean, I'm looking at, I guess, in a bigger policy question of where we should be spending some of our dollars. But am I making myself clear what I'm questioning?
Yes, absolutely, Eileen.
Laugh at me, I can see it.
That's a fantastic question, and kind of leads to what I was saying earlier about multidimensional analysis being presented to the board. There are so many different data sources that we could tap into to present information to the board, but more importantly to to seed more questions. So every set of data that you see, every set of analysis that you see prompts more questions, which is great, right? We bring you answers to those questions, and that prompts other questions, which is the purpose of bringing that information to the board. So in short, Eileen, the answer is yes. The more, I think, important part of that is what questions would the board like to answer?
Well, I guess the
And what's
problem is,
actionable.
yes, is that from what the board is charged with, that isn't exactly what we're supposed to be looking at. But I know a group up the hill that would probably be interested in some of those questions. I mean, so I guess
Yes. maybe
as a board, we have to put some recommendations forward to the legislature as to what things they could do with some of the data that you're collecting.
Thank you.
Sure, and remember there's also the project we've had with the University of Washington.
Yeah.
With Joe Dielman. I believe he's also on our March agenda to come back and talk about the next phase of work. But that next data set that he and the UW team have developed goes a little bit deeper into these geographic areas and disease burden areas.
And expenditures. But I just remember one time, 100 years ago, that Joe Campo came to the committee and did a presentation on immunization rates or it was, I think it was the pneumonia, and how much increased hospitalization we had two areas of the state where they hadn't done well with doing the pneumonia vaccine.
Yeah.
And we had increased, so it's that, I mean.
A geographic overlay.
Yes,
Yeah.
things that health policy people want to know. Inquisitive, inquiring minds.
So may I request permission to move on, because what I really want to show the board in terms of some dashboards, I think you would really like it, and that actually goes pretty in line with where I think you're headed in this.
Okay.
Can we go to the next slide? Oh, thank you. So again, some technical notes about these two data sources. Particularly, there are some challenges associated with each of these data sources. Like, for example, the performance against the benchmark data, it is complete, meaning we capture all of the, or I would say, very significant portion of the healthcare spend in the state. The APCD does not have all of that. The APCD represents about 70% of the covered lives in the state. It does not have self-insured lives. It has some, but the majority of them it does not. So there are caveats in there. The non-claims data exists in our data call, but it does not exist in the APCD. But that doesn't mean that complementing these two analyses and putting them together, we can't present a better and more comprehensive picture of the board. That's all there is to share about this slide. Any questions, any other comments about what I was sharing so far before I launch on to a bit of a show and tell?
Oh boy.
No, thank you, Michelle, for describing the differences in those two main data projects as work streams we have underway. They are complementary. And I know you want to share your screen to show us the brand new.
Yes, please.
Yeah.
If I can share my screen, thank you. Please let me know if you're able to see my screen.
Yeah, we have it.
Wonderful. So I am thankful to Michelle and the team for allowing me to present these to the board. As part of the All Payer Claims Database's mandate, the program is supposed to and required to publish healthcare cost data and make it transparent and usable to the public. One of those requirements is to publish what is called a public use file. And over the past few years, a file has been published. A year and a half ago, we did an analysis to say, well, how are people using it? And it turns out most people didn't even know it existed. Because of course, it's a flat file, it has all the data, but nobody goes looking for it other than data geeks like me. So we engaged with OnPoint to model some public use dashboards on what a couple of the states have done. We actually talked to Minnesota and said, can we please steal your ideas and your designs? And they were very gracious about it. And so these dashboards are just now becoming available. It was timely that the board was meeting today, So I thought it's a good idea to share this with the board for two reasons. One is because it is the right thing to do. We are publishing, the program is continuing to publish things, and I think it helps the board understand that there are these resources available for individuals and other entities who want to get a deeper and better understanding of our healthcare delivery system. That's one. The second is the Healthcare Authority has multiple work streams or bodies of work that are focused around and geared towards improving transparency. The all-payer claims database is a very significant body of work that the agency undertakes, and quite significantly so. These data are made public. They're not, the dashboards weren't created because the board asked for the dashboards to be created. However, we would love to get direction from the board in terms of how to improve them. If these can be, improved to better answer some of the questions that the board is leaning into in the future, I'm sure the program would be happy to take that into account and use that as guidance. The link to this website will be available in the meeting minutes and in the slides that are published online for the public. And we're going to have a communications campaign around these as well. You're just the first group who's getting to view this publicly. So they're on the APCD website, wa.healthcarecompare.com. I'm going to take a few minutes to just go through a few of the things that I think the board might find useful. Happy to entertain questions, but Kaylee has given me a hard stop at 3:35, and I'm going to try and meet that. So in this, some of the things that are obvious and we talk about all the time are there, like utilization. There are 6 different tiles in here, and we talk about utilization. There are multiple. So in this particular view, there are multiple measures that can be looked at. If my screen is too small, I can zoom in. Hopefully that's better. The measure in this that I like to look at is per member, per 1,000 members per year utilization. And as you can imagine, the clinic and office visits constitute the bulk of our healthcare system utilization, which makes sense. You'll see the heat map over here. And when I'm just going to select emergency department just for demonstration purposes. So ED visits per capita, that's what this is showing you. And you will note that in Southeast Washington, there is a very dark blue. That's Assotin County, and right next to that is Garfield County. Well, why is the utilization of emergency departments so high in the year 2022 in those counties? I think we need to go and assess how many services or what is the availability of other services, medical and physical health services, that would prevent people from going to the ED. Like, those are the things, those are the questions that looking at these data can point us to. There is another one in here. Sorry, this just became available, so I'm also getting more familiar with them. I'm going to go back and I'm going to go to services, because I think in here we have prophylactic vaccinations and inoculations. So Eileen, that goes to your question about, what's the per capita distribution of inoculations and vaccinations around the state. And as you can see, there's good utilization in Southwest Washington, which is great. We have some missing data over here, or really not much utilization per capita. But then Assotin County. So if I put the ED utilization on one hand and the inoculation and vaccination on the other hand, where ED utilization is very high, inoculation rates are really low, what does that tell me in the same geography? It kind of gets closer to, Eileen, what you were saying, but it allows us that level of analysis. The more important thing, and what I want to share with the board is, this is making this information available to the public, to policymakers, their staff, to citizen scientists, advocacy organizations and the general public so that they can go look at the data. And my team is brilliant. They can come up with a ton of questions when they look at data, but we live in our own little world, right? We can't think of all the questions to ask. Our idea is to make these data available so that there are more questions that can come up, and that will help the board sort through and say, okay, ooh, these are questions that we really should be paying attention to and asking and answering.
So the blanks, the Tri-County up in the, what's that, Stevens, I don't even know what those counties are.
Monterey.
That you don't have the information, the data yet? Is that the problem?
No, it's really low. You can see the result is 323.2 or 424. It is.
There's that and there's that bad of vaccinations.
Yeah.
I happen to know a former head of DOH lives over there. I think we could give her a call and tell her to get to work.
So going to spending data, on the members tile here, we have, we can get to a total amount paid per member per year. And as you can see, the per member per year spend has gone from about $5,500 to $6,600. That's about a 20% increase over the past 5 years, which is in line with, or pretty much in the ballpark with what we see from the data call, right? And there is ability to go down into by age group, by rurality, and like we see in here between micropolitan, suburban, and urban core areas, there isn't that much of a difference, at least for 2022, right? So, of course, Medicare, because of Medicare Advantage, we've heard about that. The actual spend is higher. And last thing I want to show is around prescription drugs.
Michelle, can I just jump in real quick?
Yes.
With a question. Thank you for humoring me. The member spend, does that include or not include the premium? So in other words, is this basically deductible point of service cost sharing?
No,
or non-covered services?
This is total allowed. This is total. So this is total amount paid per member per year, but we can say percent paid out of pocket. So that is also available.
But when I think about the APCD, right, and you're looking at claim specific data, I see the member share of an allowed amount, but I don't think that includes the premiums that consumers are paying, or is it captured?
I will have to go back and check if the premiums are reported, because this is a claims database. I do not believe the premiums will be included. It does include the deductibles, copays, and those amounts. That can be attributed to a claim.
Right. Okay. Yeah. That's what I figured. And so it doesn't include non-claim. So like a service that's not covered.
Correct.
Right?
Correct.
So what's not reflected in here from the member perspective is what they're paying for their premium and what they're paying for services that aren't covered. So no claim was ever submitted for it.
Correct. And that is one of the caveats for the APCD. The APCD provides us a lot of valuable information, but it doesn't have all the information.
And I think that's a really good when the board thinks, I mean, first of all, this is awesome. I love it. We did something very similar for mental health services a couple of years ago.
Yes.
And it's amazing. But I think when the board uses it, we just need to be sure that we're putting the context around the data so that like somebody doesn't go to the per member and say, oh, that's how much people are spending total out of pocket over the course of the year. Yes. Right? Okay, thanks.
And sorry, Kelly, I'm going to take 2 more minutes. I promise no more. For the prescription one, the one I wanted to show is, I again went to the amount paid per script. And that tells us something. It's a very high level normalization of the data, but it tells us something. The prescription cost went from $97 to $133 over a period of 5 years. That's a pretty significant jump. That's a 35+% jump over 5 years, right? So when we hear information coming I think the data here kind of corroborates what we've already heard. If I go to the prescription drug detail tab, there are a couple things that I think this group might find entertaining or interesting. But we can sort this by and group this by therapeutic class of drugs, but also by the generic name. So in 2022, this is sorted by, average amount paid per script. You can see that this particular drug, I don't know what this is, Actar, I don't know. It costs $84,000 per script. I have no idea it even existed. It made me Google it, right? So there's a lot of information in here that I think is useful. If I change the measure to the total amount paid, you will note that the sort changes to drugs like Humira, Eliquis, and Stelara with a huge amount of total spend, but the per prescription cost may not have been that high, right? So it presents both those perspectives to the user so they can assess the healthcare spend data and maybe ask some questions that are over and above or different than how we may be approaching it. I'm going to stop sharing. I'm going to yield the screen and happy to take any more questions or follow-ups. By the way, as the board reviews the cost driver analysis in your next meeting, please understand that there is this detailed data that now is made available. The cost driver analysis was done as a particular way of looking at things. It is not all encompassing, but there is the ability for us to do more, should there be a need to. And I'll stop there.
Thanks, Vishal. And I'll note I dropped that dashboard link into the chat, and of course we will send it out to board members with a few screenshots inserted in just for your reference. Okay, we do want to take just a few minutes to request your feedback about a potential assignment for your stakeholder advisory committee, and I might extend that to both of your advisory committees, the data advisory committee included too. Go ahead, Michelle. I'll let you hop in.
I'm raising my hand for Ingrid in question.
So, thank you so much. Wait, can you help me out? Okay, there you go. Data democracy is what I'm just sitting here thinking, is that, Vishal, I really appreciate the website that you just showed with a huge volume of information. And I think with transparency, there's transparency in theory, and then there's like accessible transparency. So it feels that volume will be so helpful to healthcare policy wonks or researchers or data geeks or academics. I think for the board, I think it would be helpful when we have another opportunity to digest the outcomes of all this work is having sort of top 5 trends or just things that we can all like remember and message and that are most important to think about to inform the work of this board. Because I think the more there is, the less we digest. So I think pointing out some of the trends that multiple data points are pointing to and helping us see the big picture will make this all more impactful. And if there's a way to do that in a neutral way with the tool that you just showed, I think it could, and make it accessible to more people than the inner circle of the health policy wonk data geek circle that I just described, so that more consumers could go in and say, what's happening in my community? Oh, here's how you see how your county compares to the state, or to make it more accessible.
But I'll say that I think that's much more accessible than most of the things, the dashboards I've looked at. Because I mean, like if you go in and try and look at hospital expenditures, each hospital, their list, you have to have the machine, machine readable. It doesn't work for any, hell, I can't figure it out. So I think I've got some literacy in this. So I did a good job.
Yeah, absolutely. And look forward to more time with it.
Amen.
Yeah.
Could be playing with this room.
Yeah. Great, thank you, Ingrid and all for that discussion. And I feel like that actually tees us up nicely for what we wanted to bring to you about the committee assignments, which is to really think about how is all of this vast amounts of data that we're bringing to you as the board helping to inform actionable insights? How are you getting to a policy agenda? Are we raising the right questions with the data that we're presenting? The attribution methodology that we use or just attribution period in these performance against the benchmark analyses, it assigns a patient's spending to a provider entity. Not to say that that provider entity offered the entire scope of care to that patient. It's just that the spending is all attributed to that provider. So there's some pro cons to that approach. It certainly aligns with our, population health goals that a patient has a medical home that is serving as the hub to really coordinate their care and patient experience. But is it answering the right questions for you to be able to get to what's driving those costs, what's underneath the hood, to really make some actionable insights and some policy recommendations. So there's that, big picture question about attribution. And then there's some questions about how to have that attribution approach be as accurate as it can be, and to really help support the providers to take that data and turn it into, some interventions at that level to try to control costs. So our recommendation as a staff team is for you to really tap into the expertise from your stakeholder advisory committee and your data advisory committee about these big questions that, is attribution the right approach? What are the trade-offs that you're making in reviewing performance against the benchmark in this way? And then if you do decide that attribution, you want to stick with that approach, how can we, partner with provider communities around the state, with carriers, to make it as insightful and as accurate as possible in the data? Let me pause here and see if Michelle or Vishal, anyone have anything to add to that before we open it up to your discussion and insights as a board.
Thank you for teeing up the questions for us to consider, Kaylee. I think that's really helpful baseline to start from, and to really think about the opportunities to engage these committees more actively in 2025 on some of these deep data questions. So they did give us comments at our December board meeting, and it's time to engage them actively in how we refine that. I think there's real potential to just, I'm going to steal a phrase from Vishal, really go back to the baseline question we started with, attribution. We examined that initially. The board began designing the attribution methodology when we were first designing the benchmark and how we would measure against that performance, and just followed what other states were doing, because there were a few other states in front of us. And now that we've seen how that's played out, I think it's a really good opportunity personally to just step back and say, is that what we want to measure at all? Should attribution be or not be, again, stealing Michelle's phrase, it's not just examining how we're doing, but let's examine should we do it? Because the growth benchmark is measuring overall aggregate growth, not really getting to that little individual provider level conversation, but so I really advocate that we turn that over to the committee to dive into it from a fresh start and bring back different recommendations for us.
I have a question. So when you're saying attribution, we heard, the testimony or whatever in December about the concern that it didn't get broken down enough. So is that,
So that's a methodology question. If you want to keep diving further, and I'm going to let Vishal jump in and correct me if I'm going astray here, but.
Well, the fact that you can't, because we don't know who owns what, that type, all of that, which I'm hoping there's going to be, we're going to see legislation. I don't know whether it's been introduced or not, but has it been introduced? Okay.
I remember conversations on the Hill.
Yeah. You know, I don't pay attention to those people, but I was, you know, I would hope that we're going to see some change there also. So we want to make, yes, we should have the advisory groups working on it, but I don't want it to be used, if we give an assignment to the advisory group, it's not an excuse for not moving ahead with other things. I guess that's what I'm trying to,
Sure.
having seen that used as a lobbying technique before.
Appreciate that call out.
Yeah.
Comments from other board members? Questions for Vishal around some of the fine points that we started to describe here? Vishal or Kaylee?
I appreciate the term actionable data and just directing us to what you are seeing in all of this data is the most actionable.
Yeah, I think we really need to focus on that this year because the Medicare data is fascinating, right? We could dive into that Medicare data. We are not going to, as a state, influence any behavior that's different for Medicare Advantage or Medicare fee-for-service. So I would suggest it's not worth the board's time to spend a lot of time diving into the Medicare data, even if it's interesting. You know, or the VA trends, or the Department of Corrections trends. This board's purview should be, I would suggest, around that commercial market and the Medicaid market and some of the cost drivers that will be in the next analysis, that we dive into that and identify the policy levers from that, what's actionable in policy.
Michelle, can I address Eileen's comments real quickly and maybe Eileen's concerns? Completely agree. We don't want to create more loopholes than already exist. But the idea is, you know, just like risk adjustment, the concept of attribution is good for a few purposes. And we want to really reevaluate, is it really good and useful for the board's purposes? One example is, let's say if hospital systems did not own many primary care practices, you would find that no patients, or very few patients, are attributed to the hospital system, which means in a large provider analysis, you wouldn't see any hospital systems listed at all. Is that the outcome that we want out of this decision that we made about attribution, which is really useful in value-based purchasing and ACO approaches? But for the cost board's approach, I think we want to go back to the drawing board and say, you know, is there value in attributing at all? If yes, what will be helpful from a policy and action perspective that would, you know, then inform how we approach that, as opposed to just saying, this should be the way you would do it because that's all we know. Is that helpful, Eileen? It's
no, I get it. It's just I don't want to make sure that I think this is totally fine that we need to have the advisory committees having input. I just don't want it to be used as a excuse for not doing anything, you know, like put it off another year. That's my concern.
Right.
Yeah, point well taken, Eileen. Yeah, and I just want to note we are about to launch in February the 2025 data call, keeping the methods and approach consistent from this past year with all the results that we just presented to you to get another at bat, get more partnership going. And our proposal here is that while that's running and we're continuing that good work, we dig deeper with your expert advisory bodies to really think about, is it answering the questions that you need answered?
Okay.
And refine the 26 data.
Yeah.
With that. Yeah. So not putting on hold and monitoring.
Yeah, I just want to be clear that, you know, we don't stop just because.
Exactly. Yeah.
Like a guiding principle for the next step, so that there isn't just time spent with a lot of disputing. or disagreements or,
Right.
you know, and focusing on the moving forward.
Okay. Just taking a look at the clock here, I think maybe we should move forward. Really appreciate this feedback. And of course, you know how to reach us if you have more thoughts. And I do want to call out, I appreciate the public commenters noting the expertise that they've already shared with us. We, of course, will take that into account as well. All right, let's move forward a couple of slides. Oh, and actually, I think there's a whole bunch of appendix material here that we'll have to.
121, maybe? 121?
Yep. Okay, tab 7, we are, before I start that tab 7 discussion, I just want to emphasize again the great work that Amanda and Michelle and the CUNY team have put together around answering those questions and bringing it forward. So thank you all for that presentation and time well spent. So I think tab 7, we're turning to some of the committee updates from both our committee chairs, Eileen and Bianca. Eileen, I think you want to share the first update.
Right.
Stakeholder committee.
Yes, and the assignment that the stakeholder advisory committee had gotten was focusing on medical debt. And I'll just preface this, that there was some frustration from the committee that was all, they felt like that was what they were assigned and that they wanted to do more. So hopefully with some of the tasks that we're talking about giving them, that will make them happier. We had a meeting in August that was an overview of medical debt issue and the current laws, and they identified areas where they need more information. Then in November, the consumer groups talked about the impacts of medical debt, and we've basically made some discussions and did the recommendation, and that's the next slide, just got that. The different approaches of, either trying to prevent, the main thing is, I think the big focus was they wanted prevention of medical debt. But we also talked about relief and the transparency issues in ways that we could deal with medical debt. And, some are that's more short term, but the goal being to prevent in the long term. So that's, I think, I don't really have any other questions. Oh, the recommendations are, that's the next one, is to continue to focus on the affordability as the board is doing, and focus on prevention. So that's where they came out of. And really, I guess I will reiterate again, there was a lot of concern from the committee that they felt like medical debt is the downstream issue of what we were supposed to be dealing with. So there was a lot of concerns raised by that. So I think they'll be happier with what their new job is.
Great, thank you, Eileen. Bianca.
I think I'm jumping in here. So we actually had this meeting on November 20th, actually was included a joint meeting between the stakeholders group and the data issues group. So when the two groups came together, we heard from Joe Dealman, where he talked about the analytic support initiative and the disease expenditure report. And it was just an opportunity for both committees to give some input on what they wanted to see or what their thoughts were on the rest of it. But it was really more of an update to them about what has been taking place. And then in the data issues committee meeting, we talked about and reviewed the differences in medical expenses when you look at it in aggregate versus when you look at it per member per year growth rate between 2021 and 2022. We also discussed a bit about what it looks like when we talk about a large provider organization doing reporting. Reviewed the best practices report, the NASHP report, which we'll talk about in a bit, where common features include doing things like making sure there's consolidated data and analytic capacity. This comes back as a theme later. The committee also learned of its assignment from our board here that we asked them to review the business oversight related data. So let's go to the next slide. And just as a reminder, here in the board, we discussed our recommendations around the business oversight piece of the NASHB. It comes from the NASHB State Oversight of Proposed Healthcare Mergers Model Act. Through this, there is some discussion about healthcare entities and how they should be reporting ownership structures and legal affiliations. So this was something that the Data Issues Committee was learning about, is that this is what we talked about as a board. So go to the next slide. Again, the board was, the committee, the Data Advisory Committee was learning a bit about how they were asked to review some of the reporting requirements and to investigate and recommend best practices for ownership and affiliation reporting. We asked and discussed the best practices from other states and NASHP Model Act. And the committee recommendations were asked to include, but we're not limited to the regulatory bodies that should be involved in collecting the reporting, the frequency of reporting, how that information should be made available and where, and ways in which we can minimize the burden of reporting and adapting to existing reporting requirements. And I think Harrison will take over from here, but I'll just kind of add from Eileen, I think there was a feeling that there was a lot of data reporting already happening. So I think the group really wanted to figure out, like, how can we minimize some of that burden and repetitiveness. So Harrison, I'll pass it.
Thank you for the setup. We can go to the next slide now. Oh, and so Bianca can add in here, but we certainly have the advisory committee seen a preliminary overview of what sources are currently collecting data on business oversight and healthcare expenditures in the state of Washington. You see them listed here, but we are really interested in sort of doing a deeper dive into this. So let's go to the next slide. So in an effort to sort of establish a current state and look at what elements are currently being collected in the state of Washington as it relates to business oversight and healthcare expenditures, the staff is starting on a crosswalk of these elements and how they compare to the NASHB Model Act. Essentially, what elements are collected, what elements are reported, and by whom. So we're looking at a certain specified list of data elements that are from the NASHB Model Act, model legislation, and comparing them to the current state. As this develops, we plan to solicit feedback from the Data Advisory Committee members, as well as reviewing our work in that upcoming March 27th meeting. Let's go to the next slide here. So today we're requesting feedback in the remaining perhaps 30 seconds we have here, if any, on the scope of this crosswalk and its alignment with the intent of the board's assignment to the advisory committee. So here we're looking at essentially key components of this NASHP model legislation and doing a crosswalk with the current state of data collection in Washington. This is hopefully going to inform essentially developing a system that is fit for the current landscape and perhaps one that could minimize reporting burden, something that we heard a lot about in the last committee meeting. So we're planning to focus on certain data elements listed here with a focus on high-level ownership data for healthcare entities. This could include things like business organizational structure, entities that have ownership, investment, and controlling interest, and entities that are management service organizations. And along with this, looking at unique identifiers that are linked to each aspects of that info. During key informant interviews that we're planning to conduct with partner agencies, we'll also be discussing what entities are reporting this data, to whom are they reporting it, and potential barriers for integrating sources. So based on this, we have just a quick ask. Is there any feedback that the board has for us to further guide our efforts on this as we go forward?
Bianca, wasn't the meeting before we had the public hearing in December?
Yes, this was
think.
before the public
Yeah.
hearing. Yeah.
Yeah, because I felt like at the public hearing, there was a lot of, I'm sure that people don't want to have to duplicate, so the crosswalk's a good idea, but we did hear a lot of requests for being able to drill down more and know, so that one group didn't get blamed for some of the other providers, I guess is the way I'll phrase it. So I hope, I don't know whether that was the same type of discussion that happened in the data committee or not.
I think it takes some time to get the whole committee on the same page to know what each other have and what's known and what's unknown. I think that's a big part of what ends up happening in some of our conversations is just making sure we just get on the same page. So I think that's a desire there.
Yeah, I'd agree with that. So the hope of this exercise is to, put something in front of the advisory committee that we can build on and move forward on that best practices recommendation. See a hand from Jane.
Yeah, so I saw the reference, and maybe I'm jumping ahead. I tend to do that. To full review at the next committee meeting. I'm curious, what's the time frame for all of this work?
So we're hoping to keep this overview and this crosswalk relatively high level. So we are hoping to have it done by the next committee meeting, and we can build on it in that next committee meeting. So certainly this wouldn't be a final state by any means.
Right,
Does
but
that answer your question?
I'm just curious about when the board gets looped back in.
Yeah, Jane, good question. So the first committee meeting of the year is March 27, so it wouldn't be at your next board meeting, which is March 5, but at the one after, which I think is around end of April. I don't remember quite the date. And Jane, I think I see where your head is going, which is the current legislative efforts around some of these questions. And I think we're not quite going to be able to inform everything that they're doing as we come up with this crosswalk. I'll also note that Department of Health is also actively creating a crosswalk of their own about the scope of data that they have. So I think what we're really going for today is just to get your buy-in of kind of narrowing the scope of this to really just be about the kind of provider entity structure and transparency around that component, which we know is a bill that's under consideration by the legislature now.
So I guess because of the bills that are under consideration by the legislature now, OIC, we're putting together a template of what's reported to us. And I want everybody to know that the information that's reported to us, a lot of which is referenced in the bill already, is required to be reported by domestic insurers. In other words, insurers that are licensed in Washington. So for example, Aetna and Cigna don't have to report to us, whereas, right, Premera, Regents, KP, et cetera, do. So we're happy to share whatever we come up with. And if you look at the dates that are in the bills that Senator Cleveland and Rep. Bernofsky have introduced, I think that this work, should those bills pass, can definitely inform sort of the work that DOH and OIC are going to be doing. But I hope that this work sort of is alongside and doesn't slow down the legislature's consideration of the registry bill.
Right. It's not meant to slow down that work, Jane. As you know, our teams are engaged in legislative action and support as well. So I know we've gone over time, and I want to close up the meeting and recognize that we'll have more conversations in March about some of those legislative activities. We'll include some of that in the March agenda, as well as the cost driver analysis that Michelle and Amanda mentioned. So, and I believe we have UW coming to talk about their data project as well. So it'll be, again, a full agenda in March. but we will make sure we have an opportunity to think about those assignments going forward.
Thanks.
Thank you all for your attendance and managing the subcommittees of the board and for your engagement today. Really appreciate it. With that, the meeting is adjourned.
Thank you all.
She wants to make sure we're done.